You see? Okay,
Yes, yes,
so
yes.
it's I named it After Dark Seminar. It's quite dark in
Yeah,
Seoul, 11,
it's quite
11
late for
p.m.
you.
I think 11 p.m. is the earliest. It's India is now 7:30, right?
Yes.
So I think it's maybe this time, John, is most of us has finished our daily walk, and so I think it's after that. Actually, when I visited India, I bought a whiskey in the airport, and that whiskey, name of that whiskey was After Dark. So I I decided
Okay.
to name this After Dark seminar, and today I'll talk about the definition, prevalence, and symptoms. You know, the name Nutcracker was named by Dr. Duchapel. He is a Belgian radiologist. In 1972, he named the Nutcracker, and it's caused by the compression of electrolyte vein between abdominal aorta and supraventricular artery. And its definition is clear. And one thing we should be careful is the difference between phenomenon, the critical phenomenon, and the critical syndrome. Phenomenon is just a phenomenon, compression itself. And if the patient has symptoms like hematuria, proteinuria, or left flank pain or others, we call it nutcracker syndrome. And so traditionally, it was diagnosed by the left renal, the venous catheterization, and it's usually in the first, like 1970s or 80s, the patient with growth hematuria were diagnosed as nutcracker syndrome because at the time, the, proteinuria was some left flank pain. They did not do this venous catheterization, but use this growth hematuria and the cystoscopy, nothing, and the CT scan, kidney, nothing. Then they do venous catheterization, and if there's a pressure gradient higher than 3 millimeter mercury, they made a diagnosis of nutcracker syndrome. But nowadays, we do not do the, the invasive procedure. We do color Doppler ultrasound. Nowadays, color Doppler has an excellent resolution, so we clearly see the aorta and SMA, and we clearly see the flow signals, and we clearly see the high velocity jetting here, and we can measure actual velocity with spectral Doppler. And nowadays, the Doppler ultrasound is the primary technique to make a diagnosis of nutcracker syndrome. And it's like this phenomenon, like jetting water using the watering hose. And the normal velocity here is around 40 to 50. And if it is higher than 100, we make a diagnosis of nutcracker syndrome using Doppler ultrasound. And as we have experience with the CT scan, I think the many patients with the nutcracker syndrome can be diagnosed with CT scan, and in early phase, cortical phase, contrast enhanced CT, we can see the movement of contrast opacified blood from the left renal vein into the inferior vena cava. And like this appearance is normal appearance, normal slow flow, which moves the same velocity like a plug flow. And this is another example of normal flow, like this flow is normal. But these two cases is different. It's now we can clearly see the narrow space between the aorta and SMA, and we can see jetting flow of contrast opacified blood here. And in this patient also, we can see the movement of flow with jetting into the inferior vena cava. So if we see these findings in the CT scan, we can suspect nutcracker syndrome, nutcracker phenomenon, and we can confirm it by Doppler sound and measurement of the actual flow velocity. And if it is higher than 100 centimeter per second, we make a diagnosis. That's nowadays we make a diagnosis of Nutcracker syndrome. You know, it's registered as rare disease in the United States. Two famous the sites like NIH, the genetic genetic and rare disease, the information center, NIH GAR, and orphanet. The Nutcracker syndrome is registered as a rare disease. I think the there's many reasons why they still register as a rare disease. I think because still they think that the gold standard is a measurement of the pressure gradient, more than 3 millimeter mercury. But nowadays we do not do that invasive study, so that's why still they are registered rare disease in these websites. In one of the hospitals in nephrology clinic, I did a consecutive study in more than 1,200 patients. And actually that phenomenon, this phenomenon means a peak flow velocity higher than 100 centimeter per second. About 30% of all patients visited that clinic belongs to has a nutcracker phenomenon. And among them, about half of them, so it's about 15% of all had some symptoms like hematuria, proteinuria, or other symptoms that was caused by the nutcracker phenomenon. It's so we can call it a nutcracker syndrome. So 30% and half of them are 30% had the nutcracker phenomenon, and half of them were nutcracker syndrome patients. It's a very prevalent, very high prevalence. It's quite contrast to the rare disease in the United States. I think the reason is probably they still consider the venography and pressure measurement. Venous catheterization and pressure measurement is gold standard. I think that's the difference. Another thing is many think that Nutcracker syndrome is this disease syndrome in these thin patients, but my experience is it's not that the patient limited to the thin patient, and this thick patient also had a Nutcracker syndrome, Nutcracker phenomenon. And another thing we had a wrong belief is the classical type is the narrow space between the aorta and SMA and the compression here. That is a classical type of nutcracker. But there are other types. Another more common type is this renal vein is compressed not between this aorta and SMA, but by the origin of the right renal artery directing a little bit anteriorly. You know, in very young patient, right renal artery and the left renal artery is the origin that horizontal level, but as we getting old, the aorta becomes longer and the aorta becomes rotate, and the right renal artery rotate this counterclockwise and directing a little bit anteriorly, and it is easy to compress the left renal vein by this right renal artery. So this is very common. Type 2 is actually more common than type 1. And when the aorta becomes much tortuous, then the left renal vein is stretched over this abdominal aorta. And in these patients, usually the patients are not thin and quite thick, and the space between aorta and SMA is quite wide, but left renal vein is stretched over, and the nutcracker phenomenon can occur. So actually at least 3 types, and actually type 2 and type 3 is more common than type 1. So that's why nutcracker is much more common than we have thought. We thought that only this type 1 was a nutcracker, but actually a lot of the variants in nutcracker syndrome. So this is a young man, proteinuria, and had a glomerular filtration rate fluctuation, and space here is narrow, and the peak velocity was 180, and in color Doppler ultrasound, the aorta SMA, and probably you can see the absent flow signal in this dilated, the proximal left renal vein. It means that the very sluggish flow here, and the flow is a jetting flow here, and the velocity is here. So this is a type 1 nutcracker. And in this case, aorta. So Dr. Coquel and Dr. Shen, is my explanation is clear? Are you okay following?
Yes, yes.
Okay.
Yeah.
Yes,
okay.
quite clear.
Okay,
Yes.
in this patient, and you can see this the color Doppler movie clearly, right? And now you can see the red colored flow signals here, and when it passed between the aorta and SMA, and you can see the bright colored jetting here. That is the origin of the right renal artery here. Origin of the right renal artery. It's not compressed between the aorta and SMA, but is compressed by the right renal artery here. And the peak flow velocity was 114. So this is like this type 2 nutcracker. And this is the old woman, gross hematuria and bladder symptoms. And if you see aorta here, SMA here, is space not narrow, but left renal vein is here, and it is stretched over this abdominal aorta, and you can see the jetting, bright colored jetting flow here. So this is a type 3 nutcracker, flow velocity 148. So these are examples of type 1 and type 2 and type 3 nutcracker, and actually type 2 or 3 is more common than type 1. Type 1 is usually in young patients. Type 2 and 3 are the more older and more thick patients. In some patients, the combination, more than the two types. I think this is a combination of type 1 and 2. If you see this CT scan, this is the aorta SMA, and you can see the compression here, and also you can see the right renal artery is the compressed left renal vein from posterior side like this. So I think this is type 1 component, and this is type 2 component. And ultrasound also shows type 1 and type 2 component. And you can see the flows, bright colored flow signal here. So I think type 2 component is the more important in this patient, and flow velocity is 137. So sometimes we can see the combination of more than one type, and with patient respiration, sometimes it looks like a type 1 and sometimes it looks like type 2. So it's basically there are at least 3 types. And like symptoms is variable, like hematuria, proteinuria, left flank pain. This is 3 are most important symptoms. It is caused by the left renal vein hypertension caused by this compression. If it is compressed here, there's a pressure in this left renal vein is elevated, and some veins inside the kidney is ruptured, then you can see hematuria. If the very small vessel problem, you can see microscopic hematuria. If the vessel is larger than that, so you can see gross hematuria. Also, proteinuria is the mechanism is not well established, but it is also related to the left renal vein hypertension. And if the pressure elevated in the left kidney and the capsule distended and the left flank pain can occur. And some patients have foam urine, and some patients has glomerular filtration rate fluctuation, and some think that even systemic hypertension is related to left renal hypertension. So one big category of symptom, like nutcracker symptom, is left renal vein hypertension related. Another big area of symptoms are collateral related. If if there is a hypertension in the left renal vein, left kidney try to make some collateral vessels. Most important route is the gonadal vein, is like a varicocele in men and pelvic congestion in women. But normally there are the valves here in this gonadal vein. So if valves are intact, the left kidney try to make the other collateral routes. According to the collaterals, the patient has a lot of the different symptoms. And these symptoms are quite various. The bladder symptoms usually caused by the pelvic collaterals. And if the collaterals occurs in anywhere, the patient may have the pain in umbilical area, epigastric area, subcostal area, or back pains, and even the shoulder. And actually from the head to toe, so patient can have any symptoms due to collateral vessels. Some patients have a headache problem. Some patients have an ear problem, tinnitus. Some patients have nasal problem, nasal stuffiness. And some patients shows edema. And these collateral related problems more common on the left side than right side. So the problem is the symptoms are so variable. So on the basis of these symptoms, it's quite difficult to suspect nutcracker syndrome without the experience. So I think the debate in prevalence of nutcracker, like a rare disease registered in United States sites, and my experience is quite prevalent. I think the cause is probably one is the diagnostic criteria is different. They think the gold standard is pressure gradient. I think the Doppler and the CT scan, we can make a diagnosis. And the symptoms are quite various in actually nutcracker, but they think the gross hematria is the most important symptoms. I think a lot of the various symptoms can occur in nutcracker. And they think that only this type 1 is a nutcracker. My experience, there are the type 2 or type 3. Other types are more common. That's probably underlying cause of debate existing in the prevalence of nutcracker.